I think it'd be good to talk about what therapists would benefit and how what they learn will benefit their clients. Do you
So
think? Is there anything more
no,
that
that
would?
makes sense. So
Okay.
the reason we called it, or I called it, healing the heart of trauma, complex trauma and dissociation, was because type 1 PTSD, which is the kind of thing that happens when you have even a 9/11 or the Manchester bombings or a rape or a car accident, about 30% of people will get some PTSD symptoms from that, or just acute stress symptoms, and then they will resolve on their own. But if those don't resolve and it goes on to PTSD, that's the classic EMDR 3 to 6 sessions, and you're pretty much done, as long as you had a benevolent earlier life. But with people who have been subject to what used to call type 2 trauma, and these days we would call it people who have a high score on the ACE questionnaire, which has
Okay.
10 questions about early childhood adverse experiences.
Yep.
Those with 4 or 5 of them are generally going to have a much more difficult time in life. Physical health is going to be compromised. The addictions will be very much higher in that population, and real post-traumatic stress symptoms and symptoms of dissociation and inability to manage affect in their lives. So if those clients come in and we don't know much about their background, and they present as someone who's coming in for a present day problem of anxiety or depression or whatever, and we start to treat them with EMDR therapy, that's fine, because EMDR therapy has 8 phases. As long as we don't go and step immediately into the processing phase, which you can do with type 1 PTSD, we're going to sometimes get into a difficult situation with these clients, and they're going to be destabilized if we start using processing right away, because we're not aware of it, but there's a picture of an inner instability and fragmentation. And my clinical work, before I was trained in EMDR back in 96, that's where I made those typical errors that most therapists make as well, which was to think that we could do some what we used to call uncovering trauma early on in the process without forming enough of a relationship with the client and without stabilizing them. And then people tend not to want to be doing therapy anymore.
What did you mean by a picture of? What was that? You said there's a picture of earlier of.
Okay.
Yeah, because you mentioned there's something about they have an internal picture of fragmentation or.
Oh, that they have, no, what I meant was that if we start processing too soon with people who have a long history of what I'm going to call and define for you as complex trauma, that they are going to become destabilized and they're going to
Okay.
dissociate. And we're not going to necessarily know anything about their internal picture. That's what I meant. Their
That's
map,
what
their map,
their internal picture.
right? Or
And
their map.
so EMDR activates the internal
It
picture.
activates dissociation frequently,
Okay.
because things we have to teach people. Let me back up, and you can edit it any way you want.
Yeah.
So my discovery, which was not unique to me, that a lot of EMDR therapists I was encountering in consultations or just at meetings and presentations, they were saying to me that they were afraid to be using EMDR with anybody because they'd had a couple of clients and they thought they were just really on the right track, and they started processing, and these people got really, really upset and frequently dissociated, and the therapist didn't know what they were looking at. So I said, don't despair. We all have made these mistakes one way or another. We need to develop a way to help these people feel more stable internally and more comfortable in their relationship with us, teach them enough interventions so that they can stabilize themselves when triggered, teach them what triggers are and how to kind of de-trigger situations. And when we do those things, processing is not that difficult. And so I developed a way to teach people how to determine if a person has complex trauma diagnosis.
Okay.
If we need to help them gain stability, what do we have to do? And how do we then move into the processing phase? And the other, for me, biggest piece of this work was not only that we needed to have enough interventions in a stabilization period and work that into history taking and preparation, but then when we got to the processing phase of work, what we needed to do was to notice when those particular clients had to step back into the stabilization phase and do a little bit more work because they were getting a little discombobulated by the processing work. It was bringing up too much too quickly. So we wanted to now show them how to slow down, re-regulate themselves, and then go back into processing.
By discombobulated, you mean their
They felt
nightmares
flooded.
again?
They felt flooded. They were looping.
Derealizing?
Who?
Derealization?
Yeah, there could be dissociation, derealization, depersonalization, any of their particular package of skills that they learned as a child to survive being hurt.
Okay.
There's generally some form of dissociation, derealization, depersonalization. So you want to know which of those things your client uses to survive before you start processing, right? You don't want to find yourself in trouble with them and they don't know what's happening. That's very hard to bring them back from that abyss. You would like much better, I think, to find out as you're getting to know them, what have they used over time to keep themselves safe when bad things were happening.
So you're really saying that somebody can have complex trauma. The first thing to do is to teach them how to live their life, really in managing the discomfort and dysregulation they have. That's the first thing. Well, dysregulation.
Right. Right. So when you get a person in your life, in your office, and you discuss with them why they're here, and you're taking a good history, and these days I make sure I ask everybody the ACE questionnaire, which I'll discuss in great depth at the training.
Okay.
And when I find out enough history, not too much, because again, I don't want them to flood and be upset. So we're going to take history in small bits, especially if they let me know that they have a history of dysregulation or dissociation. We're going to go real slow. When they let me know that in a variety of ways, including giving them the DES and what's called the DDIS, the Dissociation Disorder Interview Scale, and I see on paper that they dissociate, then I'm going to know even more concretely to go slowly. Form the relationship and teach them what they need to know about being grounded and centered and all the other wonderful techniques we have to teach people to take care of themselves so their life in the present, even before we start processing, might calm down a bit. Because you want them to be able to have a life in between sessions as well as in your office. That's one of the things I am the most concerned about. Because if you help somebody in the office and they do all this great work and they go outside and they spend their week dissociated or in their bedroom, then we're not really doing the job we're supposed to do. So I'm really very pragmatic and practical. And I'm going to teach people everything I've learned from other people over time, plus the few things I've developed myself to help people get into that good place. And when they demonstrate that they can do that, then we can develop targets and move into the processing phase. And that way, people are going to feel more confident and more competent to deal with the traumas of their life. Because many of these people have what you and I know are huge numbers of major traumas that started when they were quite small and involved betrayal, abandonment, neglect, and abuse from family members over a long period of time. That's, I think, a reasonable definition of complex trauma. It's not surviving a tsunami, as awful as that is, because then sometimes you have family support and societal support. But if you lived in the families these people have lived in, there's no support. You raise yourself amid horrors, real horror stories. So I want to help people get into a place where they're going to be confident in themselves and in me, that I can be a good and reliable co-explorer with them of that inner landscape of their childhood, and we can do it safely.
You're a co-explorer of the inner landscape of the childhood.
Just made that up.
That's beautiful.
Put that one in.
We'll make a meme out of it. You know what that is.
Make a what out of it?
A meme, M-E-M-E.
Yeah, I know what it is.
One of those
But
things.
I think that's too long, isn't it?
No.
No?
It's not a bumper sticker. It's
Okay, so make
we'll
one
do
and put it
so.
up. Put it under the title.
Become a co-explorer. Okay. And then, so the therapist who will benefit from this, though, is not just the therapists that work with DID.
No, this is very little about what's called DID. Dissociation is like anything else, is on a spectrum. At the front end, we have a person who had to use a few dissociative strategies when they were a kid. So they may have learned to escape into books, or these days into video games, or into athletics. They learned that they could get away from the things that are bothering them by doing some adaptive things. Now, it's all adaptive when you're being an abused or neglected child. Once upon a time, all dissociation was adaptive. However, some people were hurt so frequently that they had to learn deeper and deeper methods of dissociation, and they have become, in today's talk, DID, dissociative identity disorder.
Uh-huh.
And that's probably the most difficult in terms of planning out a good treatment conceptualization and really solid strategies.
But
And
this is for therapists who work at the other end of that.
This is for therapists who work with people who have a set of dissociative issues or strategies all the way to DID. The DID is probably the smallest part of this weekend workshop. Most of it is going to be about people who work with people who have this somewhere middle ground of dissociation. They're not DID, they don't disappear forever, they don't have alters with names necessarily, but they do have a lot of dissociative parts or ego states or neural networks, to use the AIP terminology. And we're going to help them get to know those parts and to integrate the parts into the work and not leave them out. Because very often, if you move right into processing strategies with people who have a lot of dissociative and dysregulatory problems, we're not going to know anything about what I was calling that inner landscape.
Yeah.
Who are the parts who had to learn how to fragment and dissociate when they were quite small children? We have to include them. They won't know what we're doing. They're going to feel threatened, perhaps, by what this therapist is asking of the client. Suppose the therapist doesn't know this person has a dissociative history, and everything they teach them, they say, and now please close your eyes. Many people who dissociate do not want, or who have been abused, do not want to close their eyes in your office because they don't know what you're going to do. They need to have their eyes open and feel safe. And so another way of helping them feel safe is that I introduce the idea of what their parts are, and that we all have parts one way or the other, which in fact we do. And then I will teach them to include the parts into the work so that nobody thinks something's going on behind their back. And I use the dissociative table technique by George Fraser, and I also use the idea of having a home base with a family room or a work room. It's my version of the dissociative table, where people can meet their parts and get to know them, and the parts can learn to trust the client and the therapist. And I promise them that they will be included in all phases of the work should they choose to attend. And so that's another way to help stabilize the system and develop co-consciousness between and amongst the parts and the client, and the parts and each other, and the parts and the therapist.
Well, so what I think is, let me make sure this
I teach them about staying stable is going to be taught to the whole. Need to breathe, or do you need to use the back of the head scale, or do you need to stamp your feet and stand up and just take a breathing break? So I'll know who the parts are generally, and I'll know the things that they've learned already, and I'll just call them up to memory and say, how about we do this? How about we do that? And they're generally pretty at being included, is what I found out.
So the therapists who can benefit from this workshop, though, is all therapists.
Yes, because you never know when for the first time in your practice, you're going to get a complex trauma client. Now, there are some people who tell me they've never seen a complex trauma client. And that's probably true for some people. But what I've heard later on, when I get feedback after one of these workshops, is that people say to me, I think that I was very effectively blocking somebody from telling me that they had a complex trauma history because I was simply too frightened to hear it. But now that I've learned some ways to be effective and deal with them, I'm not going to be so scared next time. And I'm listening in a different way to the clients that I've been using EMDR therapy with, because I think we've been skimming the surface. I think we could go a little deeper now. So I think all therapists who work with anybody with trauma can benefit from coming to this 2-day workshop.
really, it's if you work with the general population of the people who call and come in, there will be some with complex trauma. The
Right,
question is whether or not you see it.
correct. Um, the other thing is that many of the techniques that I'm going to talk about are things that you can use with people who are not complex trauma clients, but
Okay.
happen to go into a rough place in their life and they're feeling unstable because somebody in the family just had to go into the hospital. Somebody found out they had a terminal illness. All kinds of issues arise. And when that happens to people, they can look and act as if they have a lot more pathology than they do. And I think it's really kind of crisis work. And so it's really lovely to have some of these strategies to use with your clients, any old client, if they're coming into a rough time and they can't sort of settle down and do the work. You're going to want to know how to help them calm down. And so many of the things I use are classic stress management techniques. And we can all use those. And we can use them on ourselves as well sometimes. So I have a lot of visual imagery work. And I throw things with people, pillows, cush balls, all kinds of stuff to help them feel comfortable and in control. Also, people who have a lot of very serious illness, autoimmune diseases, chronic illnesses,
Yep.
they get stretched pretty thin. And often nobody has thought to teach them ways to cope with their illness that are more common sense stress reduction than anything else. So I think that one of the benefits of taking this workshop is that you're going to learn things you can use with other client populations as well. I was going to say there's one more thing. This is not what I would call a major alteration of the standard EMDR 8-phase protocol at all. What this really says is that, and this is why the EMDR Institute approves this course, as well as EMDRIA, is because I'm not altering the 8 phases. All I'm suggesting is that during the first 3 phases of work, all of which is preparation, that we extend it and make it more elastic to fit the needs of clients who may be experiencing dissociative problems. And then we move into processing, sometimes back to stabilization, into processing, back and forth. And it's all going to be individually set up. This is not cookie cutter, as we always say. So we can use different techniques for different clients and still stay within the framework of the protocol.
Yeah. Well, that's what I like about your work and Rogers too, is that you're really staying with the 8 phases and the standard protocol. It's just how you apply it.
Absolutely. There's no reason to
It's not confusing.
do anything different.
Yeah. People
EMDR
can,
is really full service therapy,
yeah,
I think.
really supports the basic training or the therapist training, rather than take you off in another direction that you got to figure out what to do.
Right.
So that's great.
Correct.
Okay. Okay, that's great. That's really what was wanted.
It's terrific.
So I think
Well, thank you. I can't wait to see it.
yeah, okay, very good.